Okay, so good morning. You almost escaped because originally I was going to, here we'll do this dual here. I was going to just give a brief introduction, not have any slides. Then I started to think, well, who stands up here and makes bold statements without providing evidence? And then you'd probably think I was running for office or something if I was doing that. So what I just wanted to do is give an overview of how important informatics is and data is for what we're doing on a day-to-day, hour-to-hour basis in healthcare, not just in hospitals, but throughout. This is an Aztec depiction of a sacrifice. Some people think it's the first example of data extraction that was ever done, but in fact it was not, but I thought I'd put that up to you. But one of the things I like to share is we think information, we think management, we think regulation is something that's relatively new, and it certainly is not. This is from 1772 BC, the Code of Hammurabi, and you look in there, and what they have are very precise proscriptions about how physicians are supposed to practice, how they perform their craft, what the penalties are if somebody does something wrong, and keeping of records. Imagine keeping records in stone as opposed to having to enter it on a computer every day. But the idea is information was something that had value thousands of years ago before there were even hospitals in the way people thought about healthcare. And when we think of how people got into the area of hospitals, how did information come into play with that? Before the advent of the 19th century, hospitals were places that people went to die because people of wealth could die at home. People who were poor didn't want people dying in the family living room. So what caused the change? Well, one of the first changes, yes, there we go. So Semmelweis identified that hand washing could reduce mortality from sepsis by looking at analyses of data. Something changed, looked at data, that change had importance. Florence Nightingale, spectacular individual in terms of her impact on healthcare, besides as a nurse of compassion, was somebody who organized patients into units in the Crimean War and identified that if you put people into certain categories of care and had guidelines to take care of them, you could reduce mortality by 90% in hospitals, which is what she did. How did she do it? She gathered information. She looked at data. She made changes and looked at the impact that had. The middle one here is the administration of anesthesia in the ether dump at the Massachusetts General Hospital. Not as much data-driven, but still from the perspective of technology coming together, more complex teams providing care, and providing an environment where people had to be more attentive to the details of that care. Well, as things accelerated through healthcare, we certainly saw that as healthcare became more complex, as healthcare became more widespread, healthcare became more expensive, especially in the United States, so that now we're facing the multiple missions of providing for the care of the people, of the population, and doing so in a sustainable fashion that leaves money for schools, roads, nutrition programs, and other social mandates of the organization. So how do we rely on data? Where does data take us? This is an example of where data can take us to quality and cost savings, and we certainly have those examples here at home. And this is a study that was done in 2009 American Journal of Surgery. They had it for multiple other procedures, but this is where looking at data was able to show that when doing coronary artery bypass graft, if patients had no complications and no adverse events, complication meaning something did not go as planned, but maybe there was not a consequence to the patient, down to something didn't go as planned and there was a negative consequence, an adverse outcome for the patient, that when you do things right and do things in a methodical fashion, not only do you have better clinical outcomes, but the cost of care is significantly less. Doing it the right way is the way to provide best care for the patient and the way to provide best quality. Well, here's a less complex example, and this is from my fellowship and then going into my role as an attending. Not the most sophisticated information system that was ever devised. But one of the things that we first thought about with data was we talk about big data. How big does data need to be? So my area was in risk assessment for patients undergoing surgical procedures. And one of the things we used to look at was the way This was done in institutions where you got every possible piece of information that you could get on patients. If a 22-year-old came in for surgery, you got chemistries, chest x-ray, EKG, the whole works. The idea being that the more information you had, that in and of itself made the episode safer to the patient. And we went back and looked at this and said, before we start setting up exotic systems to get and extract data, what data do we really need? And we based it on what is there evidence for that implies that it's going to have some benefit to the patient. And we found that well over half the testing that was done had no scientific basis whatsoever. And if we had went to the basis that you get information because you think there's a reasonable expectation it's going to have use to you, and by having that information be able to use it to improve outcomes, that is the basis for doing this. So by simply going to a system of getting information prior to the day of surgery for patients, cancellations were reduced on day of surgery from 6% to less than 1%. Delays on the day of surgery were eliminated, and we were able to eliminate the need for preoperative admission for over half the patients to the system. So that's by not taking big data, it was taking right data. The right data at the right time, in the right amount, and applying it in the correct fashion. So how do we do it every day here at Stony Brook? How do we do it in other hospitals around the country? Some of these numbers are small, but the point I want to make with this, and I know you're going to have some more presentations in depth on some of these as time goes on, we now, instead of getting static information that is representing what happened weeks or sometimes months ago, we are moving and have moved in many cases to real-time data that can tell us what's happening at the current time in the hospital. Now this is also information that's used in the budget side. I'll show the other information in the next slide. But this not only shows static information, but says here we can look at trends. Not just what's happening at a point in time, but where are we trending? Where were we a year ago, a month ago? What direction are we going? Down, up, straight ahead? And for those of you who are clinical, you know that in the area of clinical medicine, if somebody says a serum potassium is 4.5, it means one thing if it was 6 yesterday, it means another thing if it was 3 yesterday. So knowing where you're coming from and where you're going is important, and that's where we're moving in terms of our analytics, in terms of management of the institution. Extensive presentation on that. But we're seeing in the quality metrics where we are, where we've been, targets about where we're going, and being able to follow this over time and trend where we're seeing improvements, where we see challenges, and where we see opportunities. And this is based on having the most accurate information available that we can move on. What we are also moving to now here is, instead of looking back and saying this is where we were 3 months ago, a month ago, to with a system called Tableau, we can now look today. Who has a urinary catheter in today? Who has a central line in today? And go and make sure real time that these people are receiving the best care available using that information, which was not available to us a year ago. And it makes a huge difference having that information to guide us in a directed fashion. So where is the rest of the world in terms of looking at what we're doing and how we're doing it? We're seeing how we're making incremental changes in what we're doing with the data that we have. This is the Pacific Business Group on Health. You recognize some of the companies around here, and these are companies that are looking at care and what care costs and what impact it's having on their organizations. Highly sophisticated operations. And this group is looking for a system that's transparent about quality, cost, and outcomes of care. They want consumers to be motivated by knowing this information. They want price sensitivity as well as quality information to be out there. They want to be able to make choices on data, on information, and have their employees have that data and information available. To the extent where they're actually having their employees go outside of the region. Some of them may go to Texas to get a hip replacement, to Minnesota to get heart surgery, because they have information from across the country that says an outcome is better there, the cost is less, and this information leads them to take action that's unconventional in the way they provide care. But what has happened with all this is, as we have grown in complexity, we have something called a hassle map. And the hassle map is how many different places are involved in providing care, how many different places are involved in gathering data, how many different places have information that's of relevance to how you get your care that has a bearing on the overall impact of trying to plan comprehensive care for you as an individual. And I'm sure most of you have had the experience of somebody saying to you, how come you're all not connected? How come we all don't get access to the same information? So patients, providers, health plans, everybody's wondering how we tie this all together. And this is just a map. Occasional bothers, irritants. The basic thing behind this is, where do you go to make sense out of the system? Where do you go to pull this all together? Which is very much the place we're at right now. It's a highly complex system with large groups of people, each of whom has information, each of whom is seeking information, each of whom is trying to make something of the data that's going to make care ostensibly easier, better outcomes, and less expensive. It has in fact gotten so complex for these sophisticated companies that many of them are saying, we're out of the business. We don't want to be involved in providing health insurance. We're going to give you money to buy your insurance. Where you buy it is your business. Where you can take it with you when you leave, but we'll give you the $500 a month, $1,000 a month, and we're not going to bother, our HR department's not going to track how many times you're sick, where you get your care, who provides the care. That's all on you. The same way you buy your home, buy your car, buy your groceries, you're going to buy your health care, and we don't want to be bothered with it anymore. So how do we, at Stony Brook and other institutions, cope with this? Well, one way is we somewhat get into the area of risk. And the risk is determining how do we care for patients and how do we know when they're at risk for events and how do we mitigate those risks, both in terms of the clinical issues that they have and also the cost of the care that they incur. And one of the things that's pointed to in this is we have to think of a new way of doing things which has data analysis very much at the core of what it is. This is from two individuals, and it's from the French business literature translated, and they talk about blue ocean strategy. And it creates a point of blue ocean versus red ocean. Red ocean strategy is somebody who tweaks things to make them better. A blue ocean strategy is somebody who thinks something completely different. So in healthcare, a red ocean strategy is we've got a way to get better managed care contracts. Not particularly innovative, but you may make yourself better in a short way. The blue ocean is how do we provide care in a fundamentally different fashion to get better outcomes for populations. So some of you may have seen this picture up before. How many of you have had a film camera? Wow, that's impressive. I guess IT people, people interested in that. Kodak invented the digital camera. You don't see a Kodak digital camera on the market because they couldn't think in the blue ocean fashion. All they could think of was, we're making film, our business is film, and if we put a digital camera out there, the film business goes away and we lose our revenue stream. What they couldn't think of is we're in the business of capturing images. And if we have a more efficient way to capture images, that's a whole new way of doing what we do. So that costs them. What we have now are multiple doors to health of people who are coming into health care, and they're all thinking in terms of new ways to provide care, but again, different ways to do it through different providers, programs, virtual retail clinic. People are going to Walgreens, the hospitals, the urgent care center. These don't tie in together yet. So these are the challenges we are facing in terms of how we are providing care. And just look at everybody now who's entering into the healthcare marketplace. Walgreens, Walmart. You have companies like this, Samsung, Preventice. MasterCard and Visa now want to get into healthcare financing with a credit card that's used to buy healthcare and getting points for that. Amazon wants to get into TripAdvisor. The CEO of TripAdvisor says, we rate hotels, we make arrangements for airlines. If we can rate hotels, we can rate hospitals. We can cut deals for you. So we'll arrange a package for you to get a hip replacement, for you and a member of your family to go to the hospital. You stay at the hotel, your family member stays at the hospital, and we'll bring you home. Why not? And this person was serious. So artificial intelligence, and this is a slide I thought I had to fit in. Somebody showed it to me last week. And we think of how do we put all this information in? Is there an easy path to this? And we talk about artificial intelligence as somehow somebody comes up with a magic intelligence engine that pulls all this information together and pops out an answer for us, and we don't have to sweat the details. Well, we do have to sweat the details. The artificial intelligence is not there yet. Analytics is really just getting going now and is mature in some areas and is still maturing in other areas. But this is part of how we move along in terms of what are the analytic tools that we are learning and using and inventing to be able to help us to make the right decisions at the right time. So for some of us, we feel like we're out looking for the dangers in healthcare and somebody else is looking at us and we don't know it, and we want to get ahead of the curve as much as possible here. So just to give some insight, and I'll go quickly through these, how do we take information? What is it we're supposed to do with it? And we are supposed to take data and analyze it. We are supposed to take information and turn it into intelligence, use that intelligence to make decisions. Because it's decisions and action that make the difference, not the data in and of itself. So if you're interested in population health, and you look at this from the OECD and the United States versus other countries, let's get a little bit more precise about where we have our challenges. Our takeoff point for healthcare costs come at age 55. So the 20s, 30s, 40s aren't that far off the mark. What we do with our older population is where we are encountering significant issues with regard to divergence of cost of care. I'm at that divergence, so I'm just putting it out there, folks. If we also look at connecting healthcare expenditures, how do we get more precise in what we look at in terms of where we can target our efforts? The top 1% of healthcare consumers consume 22% of the healthcare dollars. The top 5% consume 50% of the healthcare dollars. Now, I don't put this out there in a pejorative way to say this is a group for whom dollars should be denied, but we start to get a sense as there are targeted populations based on information we have for whom focused attention can have an outstanding impact instead of making broad statements about what we are supposed to do in terms of healthcare policy in this country, and it's based on information interpreted by people who know the science behind the information and what to do. Some other examples: where is it? Heart disease, trauma, cancer, mental disorders, asthma, respiratory disease. Again, not a big surprise that there are smaller segments of the population that account for the highest consumption of resources. And why is that? Is it that they're not getting the right care? And because they're not getting the right care, and sometimes less expensive care, that they are the people who are absorbing these resources, so more focused attention is needed. Same thing based on expenditures. So I think you get the point. By having information and being able to focus on it and be precise, you are able to formulate better clinical decisions, management decisions, and policy decisions going forward. Last part of this, even more precisely, when people have chronic conditions and functional limitations, and you break them down into that, you're now really getting into the meat of where the efforts need to be able to address the needs of populations. Addressing chronic disease before it gets to become chronic disease with limitation, addressing the well patient before they get to have chronic disease, is where the best efforts are put in terms of better clinical improvement and reducing or enhancing the sustainability of healthcare. So I'll just jump ahead here. So why do I have this ad here for National Geographic? I sent one of these in. I'm scared to see what's going to come back. But I have that in there because we've talked about broad stroke in data and information, and we've talked about grand population based. Going to the other end of the spectrum, we're getting now data that's going to allow care to be more individualized. We talk about clinical guidelines for the population and applying those. But this now takes personalized, an example going to personalized medicine. In my previous system, when we put together a project to get the DNA, to get the genome for our patients, the anticipated cost was $10,000 per person to do the study. By the time we had it up and running, it was $1,000 per person. You can now get your analysis for $100. And so data is going to be used to say, here is how you are unique from the person next to you who has the same diagnosis and why your treatment needs to be different, or why your background dictates that you have different types of care. So again, that's data that is going to be useful, and data that is coming on fast, especially in areas such as treatment for patients with oncologic disorders and some other chronic diseases. So at the end, what we're really in the business about is making people healthy, finding ways to improve the treatment of disease, finding ways to prevent the occurrence of disease and disease conditions, or stated conversely, to enhance wellness, to enhance the state of health for the population. And I put this figure as the last figure here because at the end of the day, with everything that we're talking about in terms of data and information, the intelligence engine through which that information goes is as important as the data itself. I'll give you one case example. When I trained first in pediatrics before I trained in critical care and anesthesia. And in the 1970s and 80s, there were a lot of statistics about how the United States ranked 17th, 18th in infant mortality. People were shocked and humiliated. How is it that we were behind developing countries in infant mortality? The data was clear. The infant mortality in the US was this, the infant mortality in other countries was that. The data is the data. The intelligence engine put together another set of data, and the intelligence engine said that the highest predictor of infant mortality is birth weight. So an infant who's 3,500 grams at birth has a higher survival than an infant who's 2,000 grams and an infant who's 1,500 grams. So here's one set of data. Here's another set of data. How do you put that together? And the way that was put together was by people who do the care and are involved in that care saying, well, how do these interrelate? And the way they interrelated was that when you looked at each of the countries and stratified by birth weight, the United States was at the top or near the top in each of the categories. So if you were a 2,000 gram infant, you're better off being born in the US than any of the other countries. The problem was, if you were born in the US, you had a higher chance of being a 2,000 gram infant than being a 3,500 gram infant. What's the implication? The implication was that it wasn't that we needed to have different hospitals or more modernization in the NICU. The difference was having prenatal care. The difference was providing care so that mothers carried their child to term. So it was the storefront clinic that was going to have the biggest impact on this, not a new ICU. That's how the intelligence engine takes information and synthesizes it into a way that makes sense, and that is what we are looking to do as we advance informatics here at Stony Brook, that we think having informatics resting in an organization that has clinicians, statisticians, management who deal with these issues can provide the best guidance, the best answers, that we can engage in population health, we can engage in individual care that provides the greatest enhancement for the community. So what you're doing today is part of a major lift for us, and we think will be providing a defining, if not the defining edge for what we bring to healthcare every bit as much as the basic science person who is in the lab or the person who's devising the new surgical technique in our OR. So I thank you for participating and hope that gives you some broad oversight into the importance we place on this and your participation in it. Thank you.